I'd like to welcome you to this edition of the award-winning PRS Journal Club podcast with your hosts, Drs. Francesco Egro, Nicole Phillips, and Ira Savetsky. Enjoy.
Hi, everyone, and welcome to the April 2018 edition of the PRS Journal Club podcast. I'm Ira Savetsky, PRS Resident Ambassador from NYU, and as always, I'm joined by my co-resident ambassadors, Francesco Egro from the University of Pittsburgh Medical Center and Nicole Phillips from the Harvard Plastic Surgery Program. Today, we have the honor of being joined by Dr. Amanda Gosman, Professor and Chief of the Division of Plastic and Reconstructive Surgery, Director of Craniofacial and Pediatric Plastic Surgery, Residency Program Director, and Craniofacial Fellowship Director at the University of California, San Diego School of Medicine. Thank you so much, Dr. Gosman, for joining us for this PRS Journal Club podcast.
Thank you. It's a pleasure to be here.
The article we'll be discussing is Breast Cancer Following Augmentation Mammaplasty, a case control study by senior authors Drs. The late Scott Spear, Maurice Nahabedian, and Elizabeth Feldman. A quick reminder, all of the articles that we will discuss can be read for free on PRSjournal.com, including an archive of all past Journal Club articles. To begin, the most recent ASPS statistics report that approximately 300,000 women underwent breast augmentation in 2016, making breast augmentation the #1 most sought cosmetic procedure in the United States. According to the American Cancer Society, approximately 1 in 8 women will go on to develop breast cancer. While there have been many studies showing that breast implants themselves do not cause breast cancer, there are persistent concerns as to whether or not breast implants hinder the detection and/or management of breast cancer. Both saline and silicone implants can potentially obscure the detection of breast cancer on mammography, and while displacement maneuvers can improve the amount of breast tissue visualized, there is still the potential of not all breast tissue being captured. Previous studies have looked at subglandular versus submuscular placement of implants and its effect on mammographic sensitivity, with the results being somewhat variable and conflicting. Currently, there are no great guidelines when counseling, screening, or treating these patients. This study investigated trends in the augmentation mammoplasty population of breast cancer detection, staging, treatment, and to determine if there is an effect of implant pocket placement, whether it be subglandular versus submuscular, or implant fill type, silicone versus saline, on the diagnosis and management of breast cancer. This was a single institution, retrospective case control study. All cases were identified via a retrospective review over a 13-year period from 2000 to 2013 at the Division of Breast Surgery at MedStar Georgetown University Hospital. All patients had undergone breast augmentation prior to the identification of breast cancer. The control group was all patients diagnosed and treated with breast cancer during this time period. Data collection included age at diagnosis, race, age of implant at diagnosis, location of implant, implant type, mode of first detection, mammography visibility, BI-RADS score, histology, size of primary, presence of BRCA mutation, AJCC stage, biopsy modality, and treatment. In terms of the results, a total of 48 cases and 302 controls were identified for analysis. Caucasian females comprised the majority of patients at 84%. The mean size of primary tumors for cases were 1.4 versus 1.9 centimeters for the control group. Breast cancer detection by physical exam or imaging was comparable between the two groups. Of the patients that detected a palpable mass by either self-exam or clinical breast exam, augmentation patients presented with smaller sized lesions, 1.6 versus 2.3 centimeters in the control group. Breast cancer lesions in augmented patients were detectable in almost 78% of cases on screening mammography versus almost 91% in the control group, with comparable BI-RADS results. Augmented patients were more likely to undergo an excisional biopsy for diagnosis and less likely to undergo image-guided core needle biopsy, likely due to the fear of inadvertent implant rupture. Earlier stage in augmented patients approached but did not reach statistical significance. Augmented patients had a higher mastectomy rate and a lower rate of breast conservation therapy versus non-augmented patients. Subglandular replacement of implants was performed in 31% of patients versus 69% of patients who had submuscular placement. 61% of patients had silicone implant versus 39% had saline implants. Implant fill type, silicone versus saline, and anatomic locations did not significantly differ in their effect on breast cancer detection, stage, or treatment. The mean age of implants at the time of diagnosis was 14 years old, and based on the AJCC breast cancer TNM classification, no patients were found to have a T3 or greater lesion. Staging, tumor biology, and interventions, including biopsy modality and treatment, were comparable. Overall, I think this was a really excellent study Previous studies investigating this topic had much smaller sample sizes and did not have data about the type of implant as well as the pocket location of the implant. The notion that implants cause breast cancer was disproven by multiple studies in the 80s and 90s. However, concerns among patients and practitioners persist regarding the possibility of a delayed diagnosis. This study was able to show that augmentation mammoplasty results in palpation of smaller breast tumors, diagnosis of comparable breast cancer stages as non-augmented patients, which I think is a key finding, and also was more likely to be missed on screening mammography despite modern mammographic techniques. Patients with implants are more likely to undergo excisional biopsy than core needle biopsy, and are more likely to have mastectomy than breast conservation therapy. Implant fill type, silicone versus saline, and anatomic location, subglandular versus submuscular, had comparable effects on breast imaging, biopsy modality, and surgical management of breast cancer. As a whole, I think it's important when we're comparing older studies versus more current ones, and as we continue to look at studies in the future, it's important to keep in mind that it's hard to compare these studies as the quality of imaging software is different today as it was 15 years ago and will continue to change. And most mammographic techniques today include displacement views, whereas those maybe 20, 30 years were not performed. I also think it's a very timely article, as there's been a lot of press about breast implant-associated ALCL, and although ALCL is not breast cancer, the association between implants are once again in the forefront of our patients' minds. I think that we as plastic surgeons need to have a thorough understanding of these topics in order to give accurate and appropriate counseling. Dr. Gosman, I'm curious to hear some of your thoughts about this paper and how you counsel patients with regard to breast augmentation and breast cancer detection and management.
I think this is a great paper, and I think that it really does take a huge step forward in our understanding of how to address the concerns about, how effective mammography is and the issue of detecting early breast cancer in patients after augmentation. I think the way that they were able to create the case control model really puts it in kind of a different league than a lot of the previous studies. And as you mentioned, having consistency with the type of imaging also, I think, makes it very, very relevant for the discussions that are currently taking place. I think that it confirms what we have found in other studies, that mammography may be less sensitive in patients that have implants, regardless of their pocket location, and also, even with the displacement views. But I think it is very important that they were also able to clarify that this doesn't necessarily mean that there is a delay in the diagnosis. And certainly the finding that patients were detected with smaller tumor size is also very reassuring. I'm not sure exactly why this is occurring. I'm sure it's likely due to multiple factors, including, just being vigilant about monitoring, about doing self-exams and counseling patients before breast augmentation that there may be less sensitivity in screening mammography. That's certainly something that I think is important to do when you're counseling patients before breast augmentation, to explain to them that there is potentially this limitation in mammography, and really encourage that they follow the guidelines for breast cancer screening and the importance of breast self-exam as well as clinical exam, and obviously going into detail about their family history and any patients that have an elevated risk that may indicate that they need additional workup prior to or after breast augmentation.
Yeah, I think those are some really key findings. Francesco, what were some of your thoughts about this paper?
I thought this paper was a good attempt to answer a very important question, as I said, very topical. Dr. Gosman highlighted the great methodology of the study. Even though the cohort size, yes, it is large, but I think it's not large enough. And I feel due to the insufficient power of the study, not enough statistical significance was reached in many key points, and thus not allowing us to make firm conclusions, especially when considering silicone versus saline or subglandular versus subpectoral augmentation. I agree with you guys that it was very interesting that palpable lesions were detected at a smaller size in the augmented patients, but as kind of expected, fewer lesions were detected by screen mammography in the augmented patients. And to Dr. Gosman, in your opinion, What impact does prior breast augmentation have in terms of breast reconstruction options?
I think that's something that's important to look at. And when you think about why patients seek breast augmentation, not universally, but frequently people are seeking breast augmentation because they feel that their breast size is simply too small, or they are looking for a different kind of aesthetic appearance to the breast. I think that's something that frequently will lead patients who end up needing breast reconstruction to give them the option to return to that augmented size. So I think that's kind of maybe some of what you're seeing as you look at the higher incidence of having mastectomy versus breast conservation treatment, is that if they're already trying to obtain a larger breast size or aesthetic, that they are more likely to be able to achieve that with mastectomy and reconstruction than undergoing breast conservation therapy, where you're going to be reducing it with a lumpectomy and possibly dealing with additional diminution of the breast size with the radiation.
Thank you so much. Great point. What about you, Nikki? What did you think about the paper?
I thought this was a really interesting article. I still had some lingering questions after the article. I mean, one of the thoughts I had, I think this is what you were alluding to, Francesco, is that although there were smaller size lesions were detected and palpable lesions, but, with the findings that mammographic detection of lesions was lower in the augmented population, I was concerned about, were we missing patients with DCIS or very early stage non-palpable cancer? And so I think that certainly points towards future research and, I think definitely lays out the groundwork for future studies. And so I guess with that in mind, my question for Dr. Gosman would be, how do we counsel our patients about what this means for them? Does this change our consent process? Does this current article, should this affect our future counseling and consent process moving forward?
I think it's definitely very important to counsel patients seeking breast augmentation that they are not going to have, the same sensitivity of screening mammography. I think you have to be careful when you look at a paper like this that the data is not stating that breast augmentation leads to earlier detection or detection of smaller masses. That was something that was associated in this patient population. And you're right, the number of cases that was brought up is, it's 48 cases, so it does need to be looked at with caution compared to the cohort. But I think in terms of counseling the patients, and anytime you're dealing with breast augmentation, you really have to let them know that they are not going to be able to detect breast cancer potentially on screening mammography with the same sensitivity of someone without having a breast implant. And I think that's very important to impress, and specifically for any patients that have a strong family history, certainly patients that are already within the age frame that's at significant risk for developing breast cancer should undergo, a screening mammography before augmentation. And all of this should be kind of part of the consent process.
Great, thank you. One other question I had was actually sort of related to something that was mentioned almost as an aside, which was, that for the goal of implant preservation, mostly excisional biopsy was performed rather than core needle biopsy. And I'm just curious if you think that that's justified, is that what we should be doing with these patients? Like if we have, a patient that we've performed an augmentation on and they come with concerning findings from a mammography, is excisional biopsy definitely the way to go in these patients?
I'm not convinced that it's like a clear clinical indication. I suspect that, it may be more driven by the comfort level of whoever's doing the biopsy, like a core biopsy. I mean, certainly the diagnostic capability to do that safely with the implant in place exists. So I think it would depend somewhat on the comfort level of the radiologist. I don't think that patients with augmentation should automatically get an excisional biopsy. I think that you should be able to do a regular core biopsy without injuring the implant under ultrasound guidance. So I suspect that was probably, more of the preference either of the patient or potentially of the, comfort level of the people doing the biopsy.
Ira here. I think those are really great points that Francesco and Nikki brought up. And on the topic of imaging and radiology, Dr. Gosman, do you feel like most breast radiologists feel comfortable reading mammographies with breast implants? Do you feel this is a specialized skill? And should patients who are at a higher risk for developing breast cancer, should they be getting, let's say, an MRI, for example?
That's a great question. I think, as with most things in medicine, the more experience that someone has in seeing something, especially probably with radiology, the more comfortable they are about making these diagnoses. I certainly have a strong prejudice. We have, fortunately, kind of an integrated cancer center here and, dedicated mammography staff and specialists that are looking at these kind of patients routinely, both, before and after treatment of breast cancer, and as well as having large patient population with breast augmentation. So I think it definitely makes a difference if you're comparing high volume centers where they see this very commonly as opposed to potentially like a routine community-based radiology center. That would potentially be, recommendation for people who are getting their screening mammography in, a certain geographic area where they have the option to go to one or the other. I don't think we quite have the data to recommend MRI screening off the bat. Those numbers are pretty low even in this paper in terms of how that diagnosis was made, and I think there are some confounding because of BRCA patients who are going to be more prone to having MRI imaging. So I don't think we're quite there yet, but I think ultimately this study kind of sets the stage for creating a good patient comparison, really looking at things that we weren't sure about or had conflicting data on in the past regarding the type of implants, the location of implants, and ultimately really to understand this better, looking at it prospectively so that we also capture those false negative patients that, may have had biopsies and weren't necessarily included in this patient population.
Thank you so much for your comments. And I think as a closing remark, I think that this paper did really give some clarity, and certainly more studies with more patients would certainly continue to add to the literature. So I think with that, we'll end our discussion of this article. Thank you so much, everyone, for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us in the Apple iTunes Store. Also, remember to tune in to the other 2 articles we'll be discussing on this month's podcast. And finally, please join us this month for our monthly journal club on Facebook, where we will be able to interact directly in real time with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not yet done so already, and it is there where our monthly journal club takes place. And once again, thank you so much, Dr. Gosman, for joining us.
My pleasure.